to everyone. Welcome everyone to the Research Transparency webinar, which is focusing on around sharing results with participants. Thank you for joining us today. We've had a lot of interest in the webinar with around 1,000 people signing up to attend. So that's really great to see so many people interested in sharing results with research participants and learning about the requirements that are being introduced in the new clinical trials regulations. I'm going to start off with a little bit of housekeeping. So, Becky, could we move on the slides? Thank you. So, first off, as you may have heard, this meeting is being recorded. If you have any technical issues, then please contact the HRA engagement team. Their email address is there. It's engagement.team@hra.nhs.uk. And in terms of accessibility, we do have closed captions enabled for this event, so you can use those. This afternoon, the format is obviously a webinar, so there's no live chat function, so you won't be able to directly engage in chat with us over this webinar. And lots of you have submitted questions in advance, and we've tried to answer as many of those as possible within the presentations that you will hear today, and we will answer some later on as well, particularly around data protection. And then when the webinar is finished, you will receive a link for feedback about how you've found the event, and that form will be emailed to you after 4 o'clock. And we'd be really grateful if you could take the time to fill that in, because by filling that in, that will help us improve and plan for future webinars of this nature and to make them as good as we can. And hopefully this one will be fantastic. So the focus of the webinar today is, as I have said, on research transparency. The new transparency requirements in the forthcoming update to the UK's clinical trials regulations, but more specifically, sharing results with participants. But what we are really talking about today is trust. When research is trusted, people will want to take part in research and allow their data to be used. Patients and clinicians will want to use the evidence that research provides. And companies and researchers will choose the UK as a place to invest and innovate. Building and maintaining that trust is not optional, it is fundamental. Research transparency and the sharing of results shows respect to the people who contribute their time, effort, and hope to research as equal partners, not subjects of research, and it helps to earn their trust. So trust is the underlying theme that runs through everything we are talking about today. If we can move on to the next slide for the agenda. So today, you will hear about the research transparency requirements in the forthcoming updates to the clinical trials regulations, where we are as a sector in sharing results with participants, the principles and practice of sharing results, the real-life experience of sharing results in an actual study, the Kovac study, some of the practical details regarding the relevant approvals required, and finally, you'll learn how sponsors and researchers can meet the new requirements to share results with participants while still complying with data protection and confidentiality requirements. Next slide, please. So firstly, there's a lot of people on this call. Some of you will know who we are. Some of you will perhaps not have heard of the HRA before. If not, then firstly, I'd just like to say a little bit about us and our role in promoting research transparency. We're an arm's length body of the Department of Health and Social Care, and we work with other organisations to regulate and approve health and adult social care research in the UK. We coordinate and standardise regulatory processes. We provide digital systems for researchers and help reduce the burden, time and cost to do research. And we make sure that research is ethically reviewed, and we cannot do this without our community of volunteers, which includes research ethics committees and also the confidentiality advisory group. Our overall mission at the HRA is to make it easier to do research that people can trust. Next slide, please. Importantly, we actually, as the HRA, have a legal duty to promote research transparency in the UK. That's by virtue of the CARE Act. And also our vision is that trusted information from health and social care research studies is publicly available for the benefit of all. The HRA works in partnership with others across the sector to champion, change, and share data and good practice. And indeed, our Make It Public campaign is dedicated to research transparency, and it involves people and organizations across the research community working together to understand areas for improvement, discuss how we could improve research transparency, and highlight good practice. And today's webinar is part of all of that. We can move on to the next slide. So what I'm going to do now is I'm going to start off with the first presentation from myself, which will be around the changes that will be coming in the forthcoming clinical trials regulations, but also what are the current requirements for sharing results with participants and what will be the future legal requirements. So if we can move to the next slide, please. So it would seem sensible to start off with saying why sharing results actually matters. And there you see at the top, participants, not subjects. The new clinical trials regulations, the old regulations used to talk about subjects. The new regulations will talk about participants. And that marks a morally important shift about how we think about people who take part in research. Research participants have a right to know about the findings of research that they have taken part in. Providing them with a summary of the findings acknowledges and appropriately respects the contribution they have made and helps to foster trust. Sharing findings directly with participants helps build that trust, it shows respect, and helps participants to feel valued. And sharing those findings should involve more than just pointing to results, technical results in registries and academic journals, where that language is the language used in those results, perhaps written in a way that participants may not understand. Next slide, please. So what is the current situation? So currently, there are no legal requirements for research transparency, but there are policy and ethical requirements or expectations. So currently, not registering your clinical trial within 6 weeks of recruiting the first patient is a breach of the Research Ethics Committee approval conditions. And it is a good practice expectation, not law, good practice expectation that all the results are made publicly available within 12 months of study completion. The UK Policy Framework for Health and Social Care Research states that information about the findings of research should be available in a suitable format and timely manner to those who took part in it unless otherwise justified. So that's where we're starting from now. There are no legal requirements, but the next slide will move us on to the new clinical trials regulations and the research transparency requirements that are integral to the new regs. So the UK has undertaken one of the most significant overhauls of its clinical trials regulations in 2 decades. The changes are designed to protect trial participants, reduce unnecessary burdens on researchers, and facilitate the conduct of high quality, trusted research in the UK. It does bring into the legislation research transparency requirements for the first time. And these new regulations will apply to clinical trials of medicines, what we call CTIMPs, and will come into force on the 28th of April 2026. Now, the MHRA, who we've worked very closely with, who have led on developing the legislation, and we've worked in close partnership with them, they have already published yesterday their own guidance around the specific areas of the legislation covered by their remit around authorization processes, safety reporting, and other operational aspects. That's available now on their Clinical Trials Hub. Next slide. But we yesterday have produced also our own guidance covering the areas that we have a remit for, and amongst that is the updated guidance around research transparency requirements. So I'll just leave that on screen for a while. There's a QR code there. If you can fumble around, get your phones, that will take you directly to our new guidance that was published yesterday. That's now available on the HRA website. It's final guidance. We're not updating that before the new regulations come into force. That should give you all of the detail that you need to know about the forthcoming regulations, not just research transparency, but other changes. But of course, you can always contact the HRA if you have any particular queries or questions about the legislation and how to comply with it. Hopefully, you've had enough time to follow that QR code. Next slide, please. So, what are the research transparency requirements in the new clinical trials regulations? So, research transparency really refers to three things. It's registration, publishing results, and sharing results with participants. So under the new legislation, clinical trials must be registered on a public registry prior to recruitment or within 90 days of approval, whichever is the earlier. In terms of publishing results, a summary of results must be published within a year of the trial's end in the same public registry or registries, if there were more than one where it was registered, as the trial was registered in. So they're the two elements. We're not going to go too much into detail about those today as the focus is on sharing results. So the next slide focuses on sharing results. And now the requirement will be that the sponsor must offer to all relevant persons a summary of the results written in a manner that is understandable to lay persons, which is kind of legal speak, but it just has to be written in a lay-friendly, easy to understand way. That has to be offered to all people, relevant persons within 12 months of the end of the trial, unless a deferral or waiver for that element is in place. The summary results should describe the trial's results as a whole. It's not about the participants' individual results. And sponsors should consider who is taking part in the trial to ensure that they are accessible, that they are written in a format and a language that makes it understandable to the people who have taken part in the research. Next slide. So the legislation talks about relevant persons. So who are these relevant persons? So obviously the people who have taken part in the research, all participants must be offered a summary of the results. However, there are some exceptions where any of the participants lack sufficient mental capacity at the time the results are shared. Then, so for example, children under 16 who were not able to give their own consent to take part in the trial, or adults who lack capacity and again were unable to give their own consent to take part in the trial, then the summaries of results must be offered to the person who gave informed consent on their behalf, for example, the parent or guardian or the legal representative. However, it's still considered a matter of good practice for these participants that sponsors should, where appropriate, consider offering a summary of results to those people, those children or adults who lack capacity in a way that they can understand, that's in a format and a way that they can actually take in some of that information. It's not a legal requirement, but it's just good practice, as it is for those taking part in research, if they don't give their own consent, that they should be given information that is in a format and enough information for them to at least understand what they're being asked to do, even if they're not giving their own consent to take part. Next slide. So where the participant was under 16 at the time of recruitment, but then becomes 16 after, whilst the trial is ongoing, so at the time the results should be communicated to them, they are in fact 16 or older, then both the participant, the 16-year-old and older participant, and the person who originally provided consent should be provided with the summary of results. If a participant loses capacity during the trial, then the summary should be offered to a person who is engaged in caring for the participant or is interested in the participant's welfare. And that could be someone like their legal representative or next of kin. If a participant dies during the trial, then the summary should be offered to a person, again, who was engaged in caring for them or was interested in their welfare, for example, their next of kin. However, it's important to note that sponsors will not be required to actively seek out other relevant persons, but must offer that results summary if requested. We're not expecting people, sponsors and researchers, to go out and find people if people have lost capacity or have unfortunately died during a trial, where particularly that was not expected. Next slide, please. So if the nature of the trial means that participants are likely to lose capacity or die because of the nature of the study and the people that you're recruiting to that study, then the sponsors should consider how they might identify and approach relevant people to offer to share the results with them as part of the trial design. So where it's known beforehand that this is likely, then you really do need to think through and show to the ethics committee what your plans are to satisfy that offer of sharing the results with other relevant persons in those circumstances. Next slide, please. So as I mentioned, there are deferrals and waivers for these requirements, for all of the research transparency requirements, including sharing results. Deferrals can be requested for reasons particularly of commercial confidentiality, initially for 30 months following the end of the clinical trial, but extensions are possible up to a total maximum period of 10 years after the end of the trial. Phase 1 trials involving healthy volunteers will be granted an automatic deferral until 30 months after the end of the trial for all transparency requirements. And the sponsors, researchers will not have to request that. That will be automatically granted. Although, of course, the sponsor and researchers can choose not to use that automatic deferral if they wish and continue to register and publish results in the same way without necessarily needing to tell us that they're going to do that. It's an option that they can take advantage of and will be given to them automatically. In exceptional circumstances, the requirement to register in a clinical trial and indeed publish and share results may be waived entirely, but only for reasons of national defense and security only. So this would be in really rare cases, probably by studies that would be sponsored by the Ministry of Defense that involve national security, where it would not be in the national interest to make the details of those studies available to the public. So that probably will be in incredibly rare circumstances, but it is within the new legislation. So phase 1 trials with healthy volunteers will be granted that automatic deferral until 30 months after the end of the trial and will not be required to offer summary results during the deferral period up to a maximum of 10 years, as I said. But it is important for sponsors to thank participants or relevant people and provide them with a time frame for receiving results, even if a deferral is in place. So whilst there will not be a requirement to formally publish the results or formally share the results, people should still thank the people who have taken part in the research and let them know when those results will be available. Next slide, please. So which trials must meet the new regulations? So the new research transparency rules will apply to all clinical trials of medicines approved on or after what's called the in-force date of the legislation, and that date is the 28th of April, 2026. The new research transparency requirements will not apply to trials that have ended before the 28th of April, 2026. But there will be trials that have started already or will start before the implementation of the law that are ongoing at the date the legislation comes in and continue afterwards that have not yet recruited. And if that's the case, then they must register before the first participant is recruited or within 90 days of that in-force date, which is actually the 27th of July, 2026, whichever is the sooner. Ongoing trials that have already recruited a participant, if not already registered, and they should have done because it is a condition of approval currently, then they must be registered within 90 days of the enforced date, i.e. by the 27th of July 2026. Ongoing trials will not, however, need to offer to all relevant persons a summary of the results written in a manner that is understandable to lay persons. However, we do expect those findings to be communicated to participants unless there's a good reason not to, but it is not a requirement of the new legislation. Next slide. So, how can you prepare for the new regulations when they come into effect next year? So you need to start planning how and when the offer to share results will be made and recorded. Include those detailed dissemination plans in ethics applications. And then importantly, co-design those summaries that are shared with participants and other relevant persons with patient partners and test with them for clarity. Make sure that they are in fact understandable to lay persons as the legislation requires. You can, of course, refer to our existing HRA guidance, and there will be links at the end of today of this presentation, which will take you to that guidance. And do plan for any translation or accessibility needs early. As I say, depending on the people in your trial, it really needs to be made accessible to everyone in that trial. So please do plan ahead if you do need to do any translation or change the format in which you're providing those results to suit those people in your trial. And prepare to justify any deferral or, in unlikely circumstances, waiver for national defense requests. Next slide. So as promised, again, if you have your phones on you, we'll leave this on screen for a little while. Um, we have HRA guidance for sharing a summary of results with participants and our current guidance on sharing results with participants. So there's two QR codes that will take you to useful guidance that will aid you understand the requirements and understand how to satisfy those requirements. So hopefully you've had time to take a screenshot or use your phone to follow the guidance. But we'll move on to the next slide now. So thank you very much for listening to me. So next, we move on to the next presentation, which is from Dr. Dr. Angela Polanco. She is the National Head of Public Partnerships at the National Institute of Health and Care Research Delivery Network Coordinating Center. And she's going to talk to you about where we are as a sector with sharing results with participants. So, Angela, if I could just pass over to you. Thank you.
Thank you, Clive. Thank you for inviting me to talk to everyone today about the Participant in Research Experience survey. We're very pleased to be able to run this survey every year, and it's a key metric where we can see what participants taking part in research think about their experience, and it's also directly relevant to this webinar with regards to how people would like to receive the results of the research that they take part in and their experience and how it can be affected when they feel like they're not receiving the information that they would like to receive. So as Clive mentioned, my name is Angela Polanco, and I am the National Head of Public Partnerships working at the NIHR Research Delivery Network. Next slide, please. So the Participant in Research Experience Survey is something that is very close to our hearts. As I say, it gives us a real insight into what participants are thinking and feeling on the ground as they're taking part in research studies. And it's a real key factor for us to take a deeper look into what we're currently delivering and what we can change for the future, guiding us and telling us upfront what we can do to make that experience better. Next slide, please. Now, so how PRES started, it was launched in 2015-16 by the NIHR Clinical Research Network at the time. We are now the Research Delivery Network. It was created in response to a growing need to understand what the participant experience was when taking part in research and what effect that had on the ability to recruit people into research studies, and also making sure that they stay in studies once they're recruited, and that they would also be happy to take part in research again once they'd finished taking part in their original study. It was developed in collaboration with participants and public contributors to make sure that the survey itself was relevant to them and also that it was accessible. What we really want to do with the survey is to make sure that participants have a voice in the way that research delivery is shaped. As I mentioned previously, it gives us real-time information about where we can make improvements at a site level as the trial is ongoing. So not waiting until the trial has been finished, but giving us an idea about what things we can change here and now to make things not only better for the people taking part in the study, but those people who are yet to sign up. It's really important to listen to what people think and embed.
It seems as if Angela may have experienced some difficulty with the internet. Angela, you're back now. I think your internet may have just cut out.
Oh, I'm sorry. Can you hear me?
Yes, I can now.
Oh,
Yeah,
I'm
we
sorry. I didn't freeze on my
Oh, did
side.
it? It may have been my internet, in which case I
No, no,
apologize.
that's okay. Okay. I'll just carry on. If anybody's missed anything that I'm talking about, just let me know. The impact of PRES is that we are able to benchmark and share our learning about what participants are experiencing across the research delivery network, and also making sure that we develop that trust in research and taking part in research with our participants. Next slide, please. So I'm pleased to share with you some of the insights from our 2024-25 PRES survey. So this year we had just over 32,000 people taking part in the survey, telling us about what they thought about their research experience. Next slide, please. So 91% of adult participants would consider taking part in research again, and 96% of adults and 95% of children and young people felt that they were treated with kindness, courtesy, and respect by their research staff that was taking care of them. 93% of adults felt that their contribution was valued by researchers. And so overall, we have a really reassuring gauge to say that when we are recruiting people to research, that we are considering their individual needs and making sure that they feel respected along their research journey. Next slide, please. Here's a quick insight into diversity and inclusion. We do ask participants to tell us about their ethnic background and their year of birth, just to capture some metrics around who are we hearing from. Here's an insight into who we currently hear from. As you can see, the majority of the responses are from a white ethnic background, but generally when we look at the percentages of the other ethnic backgrounds as well, it's relative to census data, and we're actually seeking to improve the way that we collect responses so that we can report this more effectively and so that we can make sure that we're getting a representative voice across all of the survey responses. Next slide, please. So why does PRES matter and why am I talking to you about PRES today? So in the 2024-25 PRES, we found out that 23% of adult participants and 20% of young people didn't know how to access the results of their study. 29% of adults and 24% of young people said they didn't receive enough updates during their participation journey. And a further 15% of adults and 17% of young people didn't know how to contact their study teams in a practical way. So what does that mean for us? It means that sharing studies results we know is an issue. We've known it for a long time, and we really welcome the news that now it will be ethically expected to share the results of research with participants. We want to be able to work together with researchers and sponsors to make sure that this can happen and that the lay summaries that are sent out to participants are understandable. They meet the individual needs of the participants that are taking part in that research. And we all need to work together across the landscape in order to make sure that this can happen. And this will help us to build trust and improve the design and the delivery of research in the future. Next slide, please. And as we all know, better communication will make sure that we can have better research experiences on the ground so that people, again, will take part in research once they've finished their studies and so that they'll talk to other people about research as well and say, do you know what? It wasn't as bad as I thought it might have been. I would recommend this to my mum or to my auntie or to my cousin. So that's what we want people to take away from this, is that research is something that will help me and it will help my family and it could help the future generations. Next slide, please. So what are we going to do as part of the Research Delivery Network following the results of the 2024-25 PRES? So I shared some insights into the statistics that we've seen this year. There's some key things around access to study results and receiving study updates and contacting the study teams that we would really, really like to explore, and we would like to put into place some measures that we can improve those statistics in future surveys. So what we are going to do is a three-stage method where we want to assess what could be the issues and the barriers to this. People have told us that it's an issue, but we really want to understand on the ground with the people delivering the research and the people taking part, what is it that causes this issue to happen, and also looking outside of the box as well. So what have others done in this space and what can we learn from that? There might already be solutions out there that exist in, as I say, outside of health and social care that actually might be transferable to this space. And I really think that we can learn from other people and bring those learnings across to research delivery. We need to make sure that we are helping the people that need it the most. So people who are suffering from digital literacy issues or underrepresented populations, are they also able to access the study results, and do they need extra support in contacting their study teams? And also considering what power do we have to change things. We know that we are one part of a cog in a wider system. So by coming to webinars such as this, working together with our stakeholders and our partners across the landscape, we have more collective power in order to do this. And that has been seen by the fact that this legislation is now coming into force. That has been a number of years in the making, and it is a result of influencing and making sure that we're doing the right thing by the participants taking part in research. So we're also going to test some solutions and co-produce those at a local level with participants and their teams to see whether we can actually make a difference on the ground. And we want to continue developing PRES for all, so making sure that diversity, inclusion, and accessibility are key values that we hold for the survey in the future. And making sure, as I say, we can continue to empower and influence those that can affect system-wide change. And finally, step 3 is evaluating. So we've scoped out what we have the power to do. We've tested out some things, but we need to then report what has changed and what did we learn. So I would love to be able to come back and tell people, this is what you've told us. The legislation is now come into force, and then this has been the result of this change. Things have got better because we did X, Y, and Z. I want to be able to report how participants feel about that. Do they feel that it makes their experience better now that they have easier access to the results, that they know how to contact their study teams, and what can we do next? So really building upon that, saying it's not just good enough just to make slight improvements. We want to make improvements for the long term. And as I say, work together with our system partners in order to make that happen. Next slide, please. Finally, if you want to know more about the PRES survey or any of the results, we are hosting a webinar on the 16th of October. So if you have access to your phones and you're able to scan the QR code, there is a QR code there where you can register to come and hear more in-depth results. And we've also got a copy of the full report, which will be launched officially on Monday. So there's a QR code there, which will take you to a form where you can just request a copy, so that we don't give any secrets away before Monday. And obviously, if you want to contact my team or anybody in the Research Delivery Network about PRES, I've also popped the email address on the bottom there. So we would love to hear from you and to talk more with you about what we can do to change the way that we currently deliver research. Thanks very much.
Thanks, Angela. That's great. And apologies for interrupting you halfway through due to the vagaries of my own network connection. But that was really interesting. Thank you very much, Angela. And I've already signed up to the PRES webinar, so I will be there. That's great. So our next speaker is going to be Dr. Annabelle South, who is the Principal Research Fellow in Research Impact and Communication at the MRC Clinical Trials Unit at University College London. And Annabelle is going to talk about her work on principles and practice around sharing results with participants. So thanks, Annabelle, and over to you.
Good afternoon, everyone. So as Clive said, I'm Principal Research Fellow in Research Impact and Communications at the MRC Clinical Trials Unit at UCL. And I've worked in research communication for around 2 decades. And I did my PhD on this topic, sharing results with trial participants. So next slide, please. So we've already heard this afternoon that most participants want to be informed of the results of trials they've taken part in, and that increasingly legislation and guidance on the ethical conduct of trials expects results to be offered, but that still too many research participants don't know how to access the results of trials they've taken part in. So why is this? I've been working on communicating the results of clinical trials for the last 14 years. And when I first started getting asked about sharing results with trial participants, I naively thought it should be straightforward. But the more I've looked into it, the more complex it became. I think part of the reason the clinical trial community is so bad at this is that there are some real and some perceived barriers to sharing results with participants. There are some examples of these on this slide. Results are often not available until after the grant is finished, when there might no longer be budget to pay for sharing results, and members of the research team centrally and at sites may have moved jobs or projects. Or the trial might not have budgeted or planned for this in the first place. Sharing results with participants might not be viewed as a priority amidst the other tasks the teams are working on. Researchers may be unaware of the importance of it to many participants. There might also be practical challenges getting in touch with participants. Sharing results with participants often requires skills at making complex information clear, including writing or talking in plain language. Results from trials may sometimes be upsetting for some participants, and researchers may want to shield participants from this. It might be hard working out an approach that will be accessible for all participants, and there's relatively little evidence to guide practice in this area. And I think there are also misconceptions around the legal requirements and the legal barriers to doing this. So the QR code on the slide links to a working document put together with some major UK research funders, giving recommendations on addressing these barriers and links to resources that might help. Next slide, please. So last year, the MLC Clinical Trials Unit at UCL organised a workshop for major trial funders to discuss the evidence in this area. We developed a set of recommendations, a set of 8 principles based on these discussions for showing results for trial participants. Firstly, trial teams should proactively offer overall study results to all clinical trial participants. The research is not finished until participants have had a chance to learn the results. Results should be offered irrespective of what they show. If the trial's been stopped early, results should still be offered to participants. If there aren't any results available, information on why not should be provided, and this needs to be done sensitively. Where consent is given by a carer or guardian rather than the participant themselves, it may be appropriate to offer results to a person who provided the consent, in addition to or instead of the participant themselves. And where the participant has capacity, they should be consulted. Putting the results on a trial database or web page and expecting participants to find them based on links that they were given in the patient information sheet, which they may have received years ago, is not usually sufficient. If the trial has multiple stages or time points for results, it may be appropriate to share results as the study progresses to keep participants engaged and informed. Researchers and clinicians are sometimes more reluctant to share results of negative trials with participants, fearing it will upset them. However, research has shown that most participants still want to be informed of results, even if they may be upsetting. Careful thought should be given around how to offer trial results to loved ones of trial participants who've passed away since or during a trial. This is a sensitive issue which has potential to cause distress, but may be important for some people. And consideration of ethical and data protection issues, including whether participants consented for this, needs to be taken into account. Secondly, participants should be given the choice of whether to receive trial results. While most, around 9 in 10 participants will want them, not all will, and they should be given the opportunity to decide this and to change their minds if they want to. Thirdly, results should be offered to participants in a timely manner. Where feasible, those who've taken part in the trial should be notified as soon as the results are publicly available, ideally in parallel with the announcement of the results to scientific audiences. Participants don't want to be the last to know, and finding out results via the media rather than from the research team can be disappointing. Number 4, trial teams should manage participants' expectations around when the trial results will be available. This includes giving an approximate timescale in the patient information sheet and providing updates if this timeline changes significantly. Number 5, results should be offered in a way that's accessible to participants, both in terms of the communication mechanism and the content, including language and images. This means not simply sharing information developed for scientific or clinical audiences, although you may want to share this as well, offer it for those who want it. Consideration should be given to equity issues around how results are shared, including the communication mechanism and languages used. That includes kind of thinking about digital accessibility. Offering participants a choice in how to receive results may, if feasible, help address the different needs and preferences of different participants. Patient and public involvement is essential in thinking about planning and preparing the content to be shared with participants. Sharing results with participants requires resources. These should be accounted for in funding calls and applications. Research funders, institutions and research teams all have a duty to make sure the resources needed for sharing results with participants are planned and will be available when needed. When trial results are not shared with participants, it reflects badly on both researchers and research funders. Finally, consideration needs to be given to potential barriers and challenges to sharing results with participants at the planning stage of the study to allow these barriers and challenges to be identified and addressed. And following this webinar, you'll receive some links to further resources, which includes a short article setting out these principles. Next slide, please. Communicating results to participants isn't always straightforward, and I don't think there's a one-size-fits-all answer on how best to do it. But I do think there are some questions we can ask ourselves to help us work out what's appropriate for each specific trial. We've developed a framework based on research we've conducted in this area to help study teams work out how to communicate results to participants. The framework was published in Trials Journal last year, applied to two very different trial examples, an ovarian cancer treatment trial in the UK and an HIV treatment trial for children in Uganda, Zambia and Zimbabwe. And there'll be a link to this article sent round with the other resources after the webinar. Next slide, please. So, if you could click on, the framework covers firstly supporting and preparing trial participants to receive results. This includes thinking about how will you prepare participants for receiving results? What does your patient information sheet say about how and when results will be shared? How will you inform participants that the results are now available? Will you use an opt-in or an opt-out approach? Are most of your participants likely to want to know the results? And if so, maybe an opt-out approach might be best. How and when will you give participants the choice of whether to receive results? How will you provide support to patients who have additional questions or concerns about the results? Are they still in follow-up? Can they still access support from their research nurse or doctor? What other support is available to help them understand and process the results? Next is, how will the communication tools reach participants? Which communication channels are likely to be accessible to your participants? Where will participants be when they receive results? Will they prefer to receive them at the clinic, where support might be immediately available, or in the privacy of their own home so they can process it in their own time? Next is, who are the trial participants? What are the demographic characteristics of your trial participants? Their age, their socioeconomic status, education level, health literacy, computer literacy, access to the internet. How well are they likely to be at the time of receiving results? And how is their health and experience of side effects during the trial? What expectations do participants have around receiving results? And what will they want to do with these results? Will they want to keep them for future reference? Will they want to share them with others? Next is the results themselves. What do your trial results show? Will it be seen as good or bad or neutral news by some or all participants? How complex are the results? For example, is there important heterogeneity between subgroups, or do different outcomes go in different directions? Are the results very unexpected or surprising? Will they have implications for the participants or their family's future health or care? Next is special considerations. This includes things that have happened over the course of the trial that need to be taken into account. For example, were there changes to the trial over the course of the trial that need to be explained? Are there results from other trials that need to be taken into account when communicating the results of this trial? Has the trial closed early for efficacy, for safety, or for accrual issues? And has the trial received negative publicity. Next is thinking about the provider, so who's going to be sharing results with participants. How close are relationships between site staff and participants likely to be? How long were participants in the trial for? Was follow-up done face-to-face? Which organisation or individual was their main point of contact for the trial? Are those staff members who were the main point of contact still working on the trial? Does the communication need to be personalised to respect the relationship between site staff and participants? How many participants does each site have? And will sites with large numbers of participants have sufficient resources to share results individually? Or must other communication approaches be considered? Next up is thinking about the expertise and resources that you have access to. So what budget do you have for sharing results with participants? Have you included budget for costs such as printing and postage, filmmaking, web development? What expertise around developing patient-facing communications tools do you have? Do you have access to this sort of expertise within the team, through partner organisations, or through paying for specialist support? Is this activity seen as a priority for CTU or sponsor staff? Is sharing trial results incorporated into standard operating procedures and trial protocols? Has it been included in agreements with sites? And do sites know that this is a trial activity they're expected to do if you're planning for the results to be shared by site staff? Next consideration is communication tools. So which communications tools we use? And for this, we need to think about, can participants who want different levels of information or detail find out what they want to? So for example, can we provide layered information? What language will your participants understand? And here, thinking about what languages the patient information sheet was available in might be helpful. Do you know how to write in plain language? How will you get feedback from PPI contributors from your draft result summaries? How will you make whatever your communication tool is accessible, welcoming, and easy to follow and use? Do you have the skills to do this in-house? Do you have good templates to base it on? Do you have the budget to pay for a designer? Can you give the participants a choice of communications tools? Finally, timing. How urgently do the results need to be shared? Are your results likely to receive media coverage? If so, how can you make sure that participants don't first find out the results via the media? Do your results have implications for future treatment of your participants? Are participants still in follow-up? If so, is it feasible to integrate sharing results with routine clinic visits, or do they need to reach participants sooner than that? Are you sufficiently confident that your key messages are unlikely to change substantively to share them with participants prior to publication? And there's a link at the bottom of the screen which we shared following the session, which takes you to an editable template which has all these different questions and prompts that are on them. Next slide, please. So in conclusion, offering results to trial participants is an ethical imperative. In general, the trial community is not doing it well, in part because it can be difficult. But I know it can and it should be done well. Following the principles of sharing results of trial participants and thinking through the questions in the Show Respect adaptable framework can help plan this out. I hope the resources that will be shared with you are helpful as you think through this for your trial. Thank you.
That's great. Thanks so much, Annabelle. And yeah, that's a great piece of work. And the resources that you produced, hopefully people will be able to access them and use them for their own feeding back to participants and producing research summaries, because they're incredibly useful. So we're running a little bit fast, but I think ahead of time, but I think it's useful now if we perhaps have a quick 5-minute comfort break. Thanks to our previous presenters, Annabelle and Angela. We're going to break for 5 minutes now. So the time is 10 to 3. So we'll be back at about 5 to 3. So I will see you all then. Thank you very much. See you in a bit. University of London. And they are going to be talking about how they shared results with participants in the Kovac study. So I'll pass over to you now, Sheena. Thank you.
Lovely, thank you, Clive. So just to talk about my experience over the last, I suppose, more than 30 years, I've been working in the HIV prevention space, trying to find a product that will prevent people catching HIV. And that's been vaccines, vaginal gels, and then also tablets. And most of the trials I've been involved in have been healthy volunteer, but I've taken part in 3 trials that have been looking at clinical effectiveness and had that range of results that Annabelle talked about, from concerning to disappointing to amazingly good. So it's a wealth of experience that's been helpful. But today we're talking about a COVID self-amplifying RNA vaccine, and this was in the pandemic. We couldn't do the HIV vaccine studies, and the team switched over to help Imperial College with the vaccine they had designed. And I was really lucky to have fantastic help from our PPI representatives. And over to you, Ben.
Hi, thanks, Sheena. Thank you for your kind words. And hello, everybody. I'm Ben. I'm based in North Yorkshire, and I was diagnosed with HIV in 2000. I became very interested in HIV treatment and how it was developed, and the impact it could have on people's lives. And so I was a founder member of the UK Community Advisory Board, the UK CAB, which is an organisation that focuses on HIV treatment and treatment-related issues. And that got me then thinking about, well, how do we know which treatment is best? So that leads directly then to clinical trials. And I got involved with the Medical Research Council Clinical Trials Unit about 20 years ago now, and have been involved in their PPI group for a very long time. And it's been a fabulous and wonderful experience. So that's my background. So Sheena, tell us a bit more about the Kovac study.
Thanks, Ben. So next slide, please, Becky. To give you, are you there, Becky? Thank you. To give you some context of where we were. So this particular vaccine, we were assessing it to prevent disease, which is common with respiratory, but we also had an idea it might actually prevent acquisition of infection. It was a new vaccine technology, this self-amplifying RNA vaccine, which meant it could sort of make copies of itself within the human cell. It was the first in man, so of course safety is absolute #1 priority with those trials. But if it was safe, going forward or not going forward was going to be based on the immune responses that we could assess in volunteers. And we would have gone on to Kovac 2, which was an efficacy trial, if it's been successful. Now, if successful, the advantage of this particular platform of vaccine technology was that you'd reduce the dose by orders of magnitude. You could make far, far more vaccine for less product than you could with other vaccines. And that would mean there would be an opportunity for much wider global access than other vaccines that were being investigated. So back to you, Ben, for the next slide.
Thanks. Next slide, please. So I just wanted to clarify some of the terminology. We've been talking about participation, engagement, involvement. These are the NIHR terms. Participation is clearly understood by everyone. So if you are a trial participant, the researchers are studying you, doing things to you, taking samples from you, and you are there as a participant. But we talked about engagement and involvement. Engagement is when the research community, when the researchers present their work to the community, to the public, usually in a seminar or a webinar, or perhaps they've been invited to a community meeting, and they will tell you what they're doing or what their plans are, and they might answer questions, but it is pretty much a one-way flow of information. Involvement, though, is when you are actively involved in the whole research process. And here it's a two-way communication. So the researchers might ask you questions, might tell you what they want to do, but they will actively be wanting to hear what you think about that and the impact it might have. So it's very much a two-way process. Next, please. And involvement then, this is the formal definition, it's where patients, carers and members of the public are actively involved in the research. It's not about research being done to you as a participant. It's about being part of the research team in effect. Next, please. PPI in trials, we normally find that it's important for the PPI, the role of the PPI rep is to give that patient perspective and to really have a focus on the welfare and well-being of the participants as they're taking part in the trial. And normally you would look for PPI reps from patient groups who have lived experience or background in the disease area. And ideally, they would be well connected with the patient community because you want to have a broad viewpoint from the PPI rep about the condition that they're experiencing. It's important to have their own lived experience, but it's helpful to have a wider perspective as well. Next, please. And so what can be done? What does PPI bring to trials? There's a whole list of things there. I'm not going to go through that. We're focusing on the communicating results to participants. And here it's where any written material or any material that goes out to patients and the public and participants should be in a form that's accessible, that's easy to read, easy to understand. And then in that format, you can disseminate results not only to participants, but also to the wider community. Next, please. The point I'm trying to make here is that actually, if you have good PPI, if you have good representation, that then can improve the quality of engagement that you then have when you're communicating results more widely to the public and the communities involved. So good involvement should improve engagement. Thank you. Next slide, please. Now, I mentioned earlier, we would normally look to recruit PPI reps as people with lived experience or from people who have a background in that disease area. But at the time of Kovac, there was no such patient group. There was, that just didn't exist. So this was quite an unusual time. And that presented some challenges, I think, to how Kovac was going to do PPI. And I think I'm going to hand back to Sheena here to tell us how she overcame some of those barriers.
Next slide, please, Becky. Thank you. So of course we were lucky. Ben mentioned the fact that we had this PPI group at the MRCCTU at UCL. So the first thing that we did with respect to the involvement side was to invite Ben, an individual who had extensive experience of sitting on the independent trial steering committee. So that's the group that oversees the trial, that looks at the proposals from the researchers, looks at the results as you go along, and provides them with advice, recommendations, etc. And having somebody who had that experience meant they would not be overwhelmed by the other independent members, that they would be able to hold their own, and they would always think of that perspective from the participants. So Ben joined that committee, and then that's the group that look at the design, the protocol, and the information you're providing to participants before the trial starts, sort of before, ideally, it's going to ethics committees. But I'm sure you'll all remember the urgency of everything in the pandemic. But it was before the trial had started. So we had that advice before, and I think actually before we submitted to ethics. So the second opportunity, I mentioned that I'd taken part in these healthy volunteer studies as a clinical investigator. So luckily I did know individuals who had personal experience of being a healthy volunteer in a first-in-man vaccine trial, and one of them was kind enough and willing to join the trial management group, which is the group that meets at least monthly and brings together the study staff from the sites, and the coordinating group And it's an opportunity for the site study staff to feed back what participants are telling them. So that's actually a kind of rather informal way in which you can gather participant feedback and concerns. But in terms of engaging directly with the participants, I don't know if all of you do this already, but I think it's important to try and seek the permission during the consent process to be able to contact the participants, find their preferred method of contact. The contact will come from the clinical site, of course, because they've got the contact details. But it's really useful to have that right at the outset so that you can have a mechanism for contacting participants during the trial to keep them informed of the progress. Now, participant letters, you really do need when you've got to have consent. There's more personalized. It's something you're telling the participant about. You need them to understand, and if they need to consent to continue in the trial. A newsletter, on the other hand, is something that you can provide to all participants, and it's providing them some information that's not impacting their willingness to continue in the trial. Next slide, please. So it's quite busy, but this is the only slide I think we've got really to try and explain the timeline for Kovac. So, the virus was described and published early January, and vaccine design all over the place was starting straight away, including at Imperial. And we were ready by May, June. We understood what we were trying to do with the protocol, everything. The trial steering committee met and reviewed things. And the first part of that study was the first dose evaluation in those aged 18 to 45. And we undertook that at a single site in order to safeguard the safety of the participants and have very close oversight over what was happening. But as soon as we knew that the top dose we were looking at was safe, we expanded to 6 other sites, and we gave the first dose in this expanded safety cohort, and this was going up to the age of 75 and a much larger number of participants. So the first opportunity to look at the results with the trial steering committee came in August. Preliminary data on the dose and safety from the first 3 doses that we looked at. And we discussed with the trial steering committee the results, and the decision and recommendation was that we needed to look at some higher doses to see if we could get better responses. And so that was opportunity number 1. We wanted to invite the participants in that expanded safety cohort who'd only had 1 dose at the time we looked at the results, if they'd be willing to delay their second dose until we knew what the higher dose evaluation was going to show. So that was opportunity 2, to contact participants and provide newsletters to those who were participating but not actually impacted. And then the next opportunity, an important one, came when the first COVID-19 vaccine was actually licensed by MHRA for use. It was being offered to healthcare providers, amongst others, and we did have healthcare providers in the trial. But nonetheless, all the participants needed to know what the impact of having a licensed vaccine was on them as participants. So next slide, please, Becky. So just to rehash, those first 3 doses we looked at, 0.1, 0.2, 0.3, all safe, excellent, just mild to moderate reactions. Some suggestion that older participants had less in the way of reaction, and that's not uncommon with vaccines. But as far as the immune responses went, I'm afraid it wasn't good against the current benchmark, where the majority, if not all, of participants were responding. We had too many people who were not responding, hence the decision to look at higher doses. Next slide, please, Becky. So I mentioned the necessity and the mechanism we had for informally collecting participant feedback through the trial management group via the study staff feeding back concerns. But also each of those letters that we were sent out was another opportunity to collate and manage feedback. Next slide, please. So each of these, it's a bit small, sorry, but I've already mentioned these time points. So August 2020 and November 2020, we needed to get consent and inform some participants about the disappointment with the low dose evaluation and a request to delay their second dose. That required consent. The participants who were in the dose ranging evaluation, they weren't impacted by that change to the protocol, but they needed to know what had happened. So it was an opportunity for a participant letter and a newsletter. And that was also true once the higher dose was selected for the second dose. And then the COVID-19 vaccine rollout impacted everybody, and we were following everyone for at least a year for safety. So we wanted to get their consent to continue to do that and to explain that they could have the licensed vaccine. And then in May 21, and I'll say a little bit more about this later, we had the first publication going into preprint, and we had a webinar to share the results with all of our participants, but we knew not everyone would be able to attend the webinar, so a newsletter accompanied that too. And you can just see from all of these bits in red here, at each of these we had a chance to have Ben and Pro help us with the crafting of these. So we ensured that they could be understood by the wide range of participants that we had. Ben, I don't know if you want to add anything more to that slide.
No, Sheena, that's great. Shall we move on? Or
Yes.
do you want to go? Okay.
I think you're next, if I remember
Next
right.
slide. Next slide, please. So thanks, Sheena. And as you say, really what I'm trying to show here is that we were building on some of the foundations that we developed in the MRC CTU PPI group. That group had done some work, quite a lot of work, on the way that patient information sheets are written, or participant information sheets are written, I should say. And there were some conclusions that came out of that work, which were transferable to how the newsletters and participant letters were developed. So not only is it important to write in plain language, but also the way the text is presented has a big impact on how easy it is to read and be understood. And the headlines are the newsletter format, so 2 columns, is easier to read, and it's important to have clear headings, lots of white space, and certainly for the participant information sheets, you need a clear list of contents. So using those sort of principles, the newsletters and participant letters followed. And if I could have the next slide, please. There's an example there just of one of the participant letters. There's no need to read the detail. We're just looking at how it looks. But importantly, it's the layout and a clarity on content. So clear headings showing what was in that letter. In terms of the language, writing in plain language is not easy, and it's not a skill that everybody has. And if you are involving patient and public involvement reps in that, you may need to support them by giving them some training in the principles of plain language. But you also need to be very clear when you ask them to review something, what you mean by review. How easy is it to understand? Don't worry about fine detail of layout or whatever. If you're asking them to look at the content, be very clear what you're asking them to do. Next slide, please. This is an example from a newsletter. It showed some interim results in the sort of way that they might be presented in a journal. So a nice diagram, and there's an explanation explaining what it is. So each dot, though, is an individual person's result. And that led to quite a lot of discussion amongst the participants. They could see the general conclusion here that yes, there was a response and there was some increase in response with higher doses, but there were a lot of non-responders at the bottom of that graph. And people were very curious to say, well, which of those dots is mine? Am I did I have some response or did I not? And next slide, please. That led to quite a bit of discussion amongst the group of researchers, because should we be able to share those individual results with participants? There was concern that if we shared those results, people might draw inappropriate conclusions from that. They might say, oh, I had an immune response. I'm fine. I don't need to do anything else. I'm okay. I'm covered. I think where the PPI reps were this is their data. They have a right, in a way, to know. And so it's really up to the research team to be able to explain clearly what the results mean and how they should be interpreted. And as long as you can do that in a way that is understandable, then you certainly should give those results. And that's what Sheena and the team were able to do, both in the webinar, but also in a newsletter. So a very clear, easy to understand explanation of what it meant, and very clear that the results should not be used in any way to influence their behavior with regard to licensed COVID vaccines, because this was a research vaccine for research purposes, which had not been authorized for use by regulators. So with all that clarity, the results were able to be shared with individuals. Next slide, please.
And this is back to me, I think, Ben,
yes,
isn't it? Yes. So I mentioned that we had the first results from the dose ranging study were ready for publication in May. And as was the way in the pandemic, they were going to go onto a preprint. So they were going to be in the public domain once we had submitted to the journal. That's just the title from the journal there. And then I've also got back here the graph just to demonstrate that, of course, you do have these graphical results. Not everybody's comfortable with interpretation of those. That's the graph from the journal. But in the actual webinar, we were so lucky to have Kat Pollock, the chief investigator, and Robin Shattuck, who was the lead scientist who designed the vaccine, really put a lot of thought into the way in which they were going to explain this. They made sure there were sort of bold headlines that were in text that gave people the bottom line in terms of interpretation. We knew we'd got people who were participating who would follow the data, without any assistance, but it's got to be, as is mentioned, be accessible for all. Next slide, please. A few just thoughts for those of you thinking of doing this in a webinar. It was actually our first experience of doing this in a webinar, inviting all participants. We had done previous coordinated Zoom calls where site investigators invited participants to attend a meeting, and we were all joined up together. But this was a bit different because it was online. It was in a webinar. The timing, I think we felt it was really important that it should go on, it should be available on the day that the preprint was going to go online. We had two different shifts, an afternoon and an evening, because we knew some people would be working shifts and they'd be able to attend one or the other. We used the Zoom platform, but we also had a simple Google form. I hadn't come across this before, but it allowed people to send in questions anonymously, because I think one of the concerns about organizing this was that we couldn't really ensure that people were anonymous. We needed to have the coordinator of the actual webinar was going to need an email contact in order to send the invitation, the link to the invitation. So, of course, we had to make that clear in the invitation letter. As with all our letters, it started with a thank you, but we needed to make them know their contact details would be visible to the individual organising it. They could, of course, join anonymously, and no need at all to say they were participants, because staff were invited to the webinar too. What would be included, and that we'd be recording it for those unable to attend. We don't think we had any requests for the recording as it happened, and we only had audio. So I'm not sure in the end that would have been brilliant. The Q&A was facilitated by Ben and Pro, our PPI representatives, and then the tech from the team at MRCCT or ECL. And as I mentioned, I felt Robin and Kat did a good job at pitching it for a wide audience, and they answered questions, I think Ben really well. So I'd certainly recommend this. I thought it was a great format. Next slide, please, Becky. Thank you. This is my last one, or our last one, I should say. So I think all of us gained so much more experience of working remotely and communicating via online platforms, Teams or Zoom, and I really would recommend them. I think it does open the door to communicating with participants much more broadly. I think I felt it was lucky that I'd had this experience in prevention trials before. Having regular contact with participants in prevention trials, really frequent, you do tend to have to communicate quite a lot as you're going along. So that was a familiar experience for me. But honestly, I can't see any reason why that wouldn't be the case in treatment trials either. And then I think we did have a really equal partnership and mutual respect between investigators and the PPI reps. I think that's really important. And although, some of the concepts might be difficult, definitely with their help, you can explain to everyone. So I think that's a very achievable a possibility today. We did have great support from study staff and participants. And I should mention also, of course, ethics and regulators were fantastic with their speed of review then. And the last message is, please don't shirk away from communicating a difficult result. It's almost all the more important to be transparent in those cases. And it really can be done very well with the help of individuals who understand the community that you're communicating to. So I think that's it, Clive. Thank you. Sorry, I think we might have run over time.
No, we're fine. We're absolutely good for time. No, thank you, Sheena. Thank you, Ben. That was really, really interesting to hear your experience of doing this, and just demonstrates your obvious commitment to kind of sharing results with participants, but doing it well, and not just trying to tick a box, but actually really getting into how you can do it well and explore ways to get that information to people in a way that they can understand it. So I think that's really great to hear. Thank you, both of you.
Thank you.
So now we're moving on to our next presentation, which is from Ashley Totenhofer, who will be talking, who is our Regulatory Performance and Innovation Manager at the Health Research Authority. Ashley is going to be talking about what approvals are required and when to share results with participants. So Ashley, over to you. Thank you.
Hi, Clive. Thanks, Clive. Hopefully everyone can see and hear me. So as Clive said, I'm going to be talking through sort of what regulatory approvals were needed, when we should be doing those things, and some things you need to be thinking about when you're doing your applications. So as Clive mentioned at the start of the webinar, the new CT regs will be coming into effect next April, and they introduce this new requirement to share study results with participants. This will apply to all new CTIMPs submitted after the 28th of April. It's not, however, not a requirement for studies that have already been submitted. However, we would like all studies to follow this as much as possible. There won't be a requirement to do so, but it is best practice. And similarly, obviously, the CT regs don't apply to non-CTIMP trials. But again, we think this is best practice, and we'd like all research to do this wherever possible. We do know, however, there has been some confusion over what approvals are needed, some questions about what people can do, how to do this, and hopefully this session will clarify some of this for you. So first off, I'm going to spend a little bit of time talking about what needs to go into your initial application, some of the things you need to think about when you're sort of writing your application to the rec. I'm going to cover a little bit about what do you do if things change during the study. I'm then going to go through a little bit again about other relevant people. So when might this apply to your study? What else you might need to think about, and how you might go about ensuring that you've got you're contacting the relevant people. I'm also going to touch on some of the results in a registry versus sharing the results with participants. What is the difference between these, when we might need to do what you might need to do for each one. And then, as Clive said, finally, when should you be sharing these results? So can we go on to the next slide, please? So when you apply to the REC, we advise you to think about how results will be shared at the start. So when you're designing your project, when you're writing your application form, start thinking about this then. It may seem like it's a long way off at that point, but it's much easier to build it in from the study from the start. If you're going to be thinking, oh no, it's going to cost money, putting that into your budgets at the start, it just makes it much, much simpler. So RECs are going to be interested in this as well. There is something they're going to be asking you about. The IRS application form has some sections on it asking what your plans will be. The RECs obviously will be looking at this. So if you aren't planning to do it, you will get questions from the REC. If you just say we're not going to do this, they will raise objections to that. So you need to be thinking about it at that point. You also need to consider how you're going to be sharing these results. So what format are they going to be shared? It needs to be in a way that will make sense to participants and will work for them. So who's going to be sharing them? Will it be the study team who's doing this? Will it be a CRO, a CTU, or a sponsor? Because depending on who's going to be doing it, you might need to collect different data, different information. Obviously, if it's the study team at the ground on the trust who are going to be doing it, probably all you need to do is collect the name. They'll have contact details. If, however, it's going to be a CRO or the sponsor who's going to be sharing this, you'll need to collect some more information. So what do you want to actually collect from them? How are you going to share it? If you're going to send out emails to people, will they all have an email address? If they don't, what are you going to do for those people? If you're posting them out, obviously you'll need home addresses. Are people likely to be moving? How long is your study going to be running for? If your study is running for 6 months, you might think it's unlikely that too many people will be moving, so that's fine. If, however, it's going to be running for 10 years, obviously there's a greater chance that people will move. So these are sorts of things you need to be thinking about. Obviously, we know people have questioned about GDPR. What can we collect? How can we keep this? But as long as you're collecting the minimal amount of identifiable data you need, and you're telling people what you're going to be doing and what you're going to be using it for, that shouldn't be a problem. So you need to put this in the participant information sheet. So when you're writing those information sheets, you should be explaining to people that you're going to be planning to share the results after the study in whichever way you decide. And to do that, you're going to collect these bits of information. As part of that as well, you probably want to give people the option to opt out. So whilst we expect most people would want the results of their study, if someone says, no, I'm not interested, I don't want to know, we need to respect that. So give them the option to opt out if they don't want the results to be shared with them. And again, I've touched this already, but if contact details like to change, think about how this might get updated. So we don't expect researchers to be actively monitoring email addresses for people, postal addresses. That's not feasible, that's not sensible. But if you need some way, so if a participant moves house and they're going to post it out, they can tell you that their address has changed, so you can update those details. So when you're writing an information sheet, again, putting in some information there about how participants may contact you if they want to change things. The other thing you need to think about is if the study changes if the things change, the study happens. Obviously, people who have run research will know quite often there'll be amendments. The things may change as the study runs. So if this would change what you're going to share with people, how you're going to share it, you'll need to notify this to the REC. This would normally be done via an amendment, but that's what you need to think about that. So I said at the start, there isn't any requirement to share results for studies submitted before the 24th of April, but we would like you to be doing this for those studies as well. But if you hadn't thought about this previously and now think, oh no, I need to collect some more information, again, that is something you may well need to submit to the REC as an amendment. Hey, next slide, please. So Clive mentioned other relevant people before, so I'm just going to go through this a little bit more. So, is this going to apply to your study? A lot of times, no, it won't matter. That's not something you need to think about. But if your study involves any children, any adults unable to consent for themselves, you'll need to think about this. Similarly, if you've got any adults who are likely to lose capacity or likely to pass away, again, this is something you'll need to think about. So you'll need to think about these things when you're setting up your study. If you've got children involved in the study, it's fairly straightforward. As part of the consent that their parent or guardian provides, you can ask them if they want to be informed. So again, you can put all this information in the information sheet and make sure that's taken as part of the consent process. One thing that needs to be recognised here is the results should be shared with both the parents and the child. So you may, as well as having, when you come to writing your results, having one format that's for the parents, you might want to have another one that's in more child-friendly language. Obviously, it would depend on the age of the child, what that looks like, but it's something you need to think about. And the other thing to be aware of with children is if the child becomes an adult whilst in the trial. So if they're recruited initially when they're, say, 14 or 15, once they finish the trial, they're over 16, they're technically an adult under the clinical trials regulations. You would still need to be telling both the parents and the child, sharing those results with them. If your study involves adults who can't consent for themselves, again, it's relatively straightforward. There would be a legal representative, quite often that's a family member, who would be acting as a consultee, and they, as part of the consent process with them, you can ask them if they want to have the results shared with them. Again, all can be put in the information sheet, so it's all clear, it's all recorded. One thing that's slightly different with some ALC research or some research involving adults who can't consent is emergency research. So this is research that happens, and the participant may not be able to consent at that point, but the research needs to be done in emergency. So then the consent might become from a professional consultee, but we'd normally expect people to go and be seeking consent either from the individual if they regain capacity later, or a family member, the normal consultee. So we wouldn't expect you to be getting consent to share results at the initial point, but when you go back and get that further consent, that's when you could be asking the family member or them about sharing the results with them. The other studies where you need to think about other relevant individuals are ones where people may lose capacity or may pass away. So here you need to be obviously sensitive and think about this. Is it an anticipated outcome from the study? Obviously, some studies, some conditions, you may expect this, and potential participants may understand this. So you can ask them the question, it's not going to worry people. But obviously, you don't need to ask it for all studies, and we wouldn't want to be asking everybody who's entering every study, what you want to happen if you pass away. So you need to consider carefully your patient cohort, the type of study here. But if you think this is something that might happen, again, this can all be put in the information sheet, make it clear to them what will happen, and you can ask them at that point, who would they like the results to be shared with. Moving on then to the next slide, please. So there's summary results versus share results with the participants. So the new CT regs also have a requirement for sponsors to update the registry that they've registered their study in. So this tends to be a more technical language, but may include a LACE summary. But the updating this registry is not the same as sharing results with participants. You can't say, okay, we've uploaded our summary of results in this registry, even if we've got a LACE summary there, that doesn't mean you've complied with the legislation. So you do need to make sure you are updating the registry, and you are also sharing the results in a format, sharing results directly with the participants. Next slide, please. And then when should you be sharing these results? So ideally, as soon as possible, as soon as they're ready after the end of the trial. The idea, it's letting the people know what's happened to them. We don't want it to take ages. So as part of the UCT regs, I've mentioned the registry needs to be updated within a year of the end of the trial. Quite often that would be when the trigger would be to inform the participants as well. There is no need to seek REC approval for these summary of results that you're sharing with participants. So the REC doesn't need to see the results you're sharing with them, the documents that you're being asked to share with them. It's fine. It doesn't need a REC approval. If you want to tell the REC of the summary of results, you can do. That should be done via the final report to the REC. So you wouldn't need to go and get a separate ethical opinion for the summary of results themselves. There are some times when you might want to do this much sooner, though. So if you have, say, a platform trial or an adaptive trial with lots of different arms, you might be able to share results for one particular arm much sooner than the whole study. So if an arm is finished, you've written up the results of that arm, there's nothing stopping you sharing those results at that point. You don't have to wait for the end of trial. You don't have to wait for the whole thing. If it works and you've got results you can share, go ahead and do it straight away. Similarly, if there's a study with a long-term follow-up period, it might be possible to share interim results whilst that follow-up period is ongoing. So you might be able to share something with people when their active part of the study is finished, but with the understanding that maybe you're going to follow up with them again once that sort of 5-10 year period is ongoing. So there's nothing stopping you from sharing results before the study is finished, if that would work for the trial. Obviously, it won't work for all trials, so you would need to think about it, but it's not a case of you have to wait for the end of the trial. And another key thing here is sharing results with participants should not affect any journal publications, any conference publications. Just because you shared results with participants will not mean that they're then going to say, "Oh no, this has been published. You can't publish here." We've had confirmation from these that won't have any impact. So there shouldn't be an excuse to say, "Oh, we're not going to share the results with our participants because we're waiting on a journal." You can go ahead and do it before that happens. And that's everything from me. So I'll hand you back over to Clive.
Brilliant. Thanks, Ashley. Really helpful practical advice for people to work out when they should share their results. So we're going to move on now to perhaps more practical advice. I just want to say thank you to everyone on the call who did submit questions. As I mentioned earlier, we've hopefully managed to incorporate a lot of those into the presentations that you've heard already. But we did receive a lot of questions and have been receiving questions whilst we've been developing our guidance around the clinical trials regulations relating to particularly data protection and the confidentiality requirements. And so we've invited Alison Knight, who is the Health Research Authority's Data and Privacy Specialist, along to this webinar to give us a bit of an overview of how sponsors and researchers can meet the new requirement to share results with participants and other relevant persons while still complying with data protection and confidentiality requirements. Of course, we think there's a few misapprehensions, misconceptions, some confusion out there. So hopefully Alison will give us all of the down low on how to comply with data protection. Thanks, Alison. Over to you.
Yeah, thanks very much. So as Clive said, I'm Alison Knight. I'm Data and Privacy Specialist for the HRA, and I advise on information governance. I'm going to shorten that to IG for speed in all aspects of research. So yes, this is a question that has been raised, as Clive said. So I'm happy to, I don't have any slides, but I'm happy to talk through for a few minutes to give you some practical IG tips on how sponsors and researchers can meet this new requirement while still staying legally compliant. And of course, when we're talking about IG concerns, so when your IG team or professional comes and asks about this, at its core level, we're talking about collecting and keeping patients' people's contact details linked with health information. And in some cases, those details have to be stored for many years, for example, where a deferral has been approved. I think the other aspect to sort of set the scene here is that when I talk about IG rules, I'm really talking about three things. So we've got the complete picture. So first of all, data protection law, most of us have heard about UK GDPR and the Data Protection Act, and that says at core that you should minimise the data that you hold, keep it at only as long as needed, and protect it with appropriate security. But the second sort of pillar is the common law duty of confidentiality, not as well known, but it also protects patient and service user information. And it means that you can't share such information outside the patient's care pathway unless you've got consent or another legal basis. And that applies even after a patient has died. And third, sort of to bring those three together, we've got the Kovac principles. So these are the best practice standards we use in health and care about justifying what you do with patient information, again, using the minimum necessary and being accountable. So the challenge that some IG teams may come up with is, and that you have to deal with, is how do we deliver on this new legal duty that we've all heard so much about, while still respecting all of those IG rules and making sure the safeguards are in place? So I'm going to break it down into a few questions for ease. And I think the first question that we get is it lawful to keep people's contact details long enough to share the results? And the easy answer is yes. Sponsors can collect and keep contact details for sharing results, but as Ashley's mentioned, only with a consent for that purpose. And in the same vein, yes, those details can be held for long periods, even up to 10 years if a deferral is granted, as long as this is explained, proportionate and secure. So what I mean by that in IG terms is only collect what you really need. Usually that's just a name and a contact method as agreed with your individual. Be really clear up front about why you're getting this information and for how long you're holding it. And of course, delete the information when the purpose is complete or before that when a request is made for deletion. And so this is a way of satisfying both data protection law and confidentiality, in particular the minimum necessary principle. So then the second question that might be raised is, how do we avoid breaching IG when contacting people? And I think at an IG level, the clearest answer is to make that choice about receiving results separate and simple. So don't bundle it in with the main trial consent. And so at its simplest level, at recruitment, explain clearly that this is a different decision. Would they like to be contacted later with a summary of the trial results? And if they say yes, record that as a yes, no on the consent form, independent of their decision to join the trial itself. And then give them a really straightforward way to change their mind at any point. And you have to make that, easily operational. So this is all about, building that into your design considerations, and the transparency and the ability to opt in or out meets both confidentiality and Kovac standards on openness and accountability. So let's bring in the time factor here. So what if results aren't available for years? And this isn't uncommon, as I said. If results won't be ready within 12 months, sponsors can apply for a deferral. And as I said before, during that period, contact details can still be held if it's clearly explained and kept proportionate. I think the additional question that we hear more of that your IG teams might be interested in is, how do we keep these details accurate? And so the law says sponsors must take reasonable steps to ensure accuracy. But what we don't mean here, what the law doesn't mean, is chasing participants and monitoring them over time. And I think the proportionate approach is to say at the start, you are responsible for updating your details, and then provide a simple, accessible route for them to do so, like a central email address or a secure portal they can log into to change their details. So then again, let's touch on this point of who should hold the data and send results. Well, as we know, the buck stops with the sponsor, so most of the time that's the sponsor's responsibility. But as Ashley said, sometimes it's less intrusive from an IG perspective and more practical for sites to do it. And that's precisely because they already hold identifiers, or they may be seeing the participants face to face. Or indeed, you could a CRO could do that by managing it under contract. I think from an IG perspective, the main thing is clarity here. So roles must be set out in the protocol and agreement, consent has to be in place for whoever holds the data, and the right security standards must apply. And then we've heard Ashley also talk about what about relevant persons or if participants withdraw. Well, of course, the essence of IG is that participants can withdraw at any time, withdraw their consent, change their mind. And as I mentioned, we need a way to remove their details if they no longer want to hear from you. That's really important, and doing that efficiently and timely. But you also need to plan for situations where relevant people may want the results instead. For example, as Ashley mentioned, if the participant loses capacity or dies. So in those cases, you can collect the relevant person's details, but again, consent is central here, and also keeping that information asked minimal, proportionate, and secure. So just adding to a little bit of a layer on that. So one important safeguard is confidentiality. So if a participant has actually said they don't want to receive results, that choice should take priority. That's the right decision ethically and legally, even if a relevant person later asks. And this has quite a direct IG angle, actually, because you should also take care not to disclose confidential information indirectly. For example, by confirming that someone was in a trial or not. In that situation, the right approach is to provide access to the general trial results without confirming an individual's participation and inadvertently leaking their sensitive health information. And of course, I think the last aspect here is what if direct consent isn't possible? And we know that's the case sometimes. So there are studies using anonymous samples, for example, or where confidential patient information is used without consent under Section 251 support. So in those situations, you need to explain this upfront. That's really important, and make sure that results are still published in a place that people can access, such as the registry or sponsor website options we've heard about. But where you do hold identifiers and consent for this purpose, you must use them. In that situation, publication alone is not enough to meet the requirement. So I'm just going to sum up, if I may, for a couple of moments. What are the key IG points to take back with your IG teams and to think about as you design your study? First of all, consent is needed to use contact details for sharing results. Keep it simple, keep it separate. Second of all, identifiers can be held long-timed if it's explained, proportionate and secure. Third, roles must be clear. This is really important. Think about that right from the start. Usually it'll be the sponsor who holds the data, but it may be agreed otherwise. But think about that straight up. Fourthly, participants and relevant persons can change their mind, and you must respect that and be able to affect that change of wishes and to implement those change of wishes easily and on a timely basis. And fifthly, if direct contact isn't possible, results must still be published accessibly, but publication isn't enough if identifiers and consent are held, allowing you to directly reach out to them to comply with the regulation requirement. So what I hope to show you is a bit of a whistle-stop tour, but if you follow these guidelines, these key principles, you can meet the duty to offer results in a way that is safe, lawful, but also maintains public trust. And that's so important to the way that research is carried out from the very start, right up to that point where you share the results and onwards. So you don't need to remember all of this. We have put out some written guide. I think one of my colleagues might even post it in the chat for you all. Please take a look at this, digest some of what I've said, have a look at that more detail, share it with your IG teams. And we really hope, and I promise you, it will give you the assurance that you need to proceed with confidence. And that's what we're really all about, planning and proceeding with confidence when it comes to IG. So thanks, Clive. Let me hand back over to you.
Brilliant. Thanks so much, Alison. That's really helpful again, really helpful practical advice. And yeah, just to reiterate, all of that advice is available in our newly published guidance on our website to support the implementation of the clinical trials regulations. So please do go and have a look at that. So in the next session, as I mentioned, we did receive a lot of questions. Now, there was one final important question that it might be helpful that we could maybe kind of put to our presenters so far. And that is, how do you change hearts and minds to ensure that the sharing of research results is not only supported, but understood and embraced by the research community? As we've been hearing today, there are new legislative requirements coming in for sharing results for clinical trials of medicines. But of course, sharing results applies to all research. But legislation by itself doesn't solve anything. If it did, we'd probably already be in a much better world than we are now. The legislation perhaps sets a marker, but I want to go around and ask our presenters their thoughts on how do we change culture, change minds. Legislation, yes, but how do we get people to believe it, feel it, and care about it? Could I come to maybe start with Annabelle, if that's all right? Do you have any thoughts on that particular issue?
Yeah, I think one of the keys is to increase understanding in the clinical trial community, so researchers, funders, site staff, everyone involved, of the importance of receiving results to many participants. We need to be listening to the views of participants rather than making assumptions about what people want and don't want. So that includes communicating difficult, complex, potentially upsetting results. Really, when I've done my research, I've come across site staff who thought participants weren't interested because they didn't ask. And I've spoken to participants who didn't want to bother busy site staff. So there's this real disconnect. People don't realise how important this is. But through my research, I've seen how valued it is and how important it is as part of somebody's research experience. So I think that's my key take home for that.
Brilliant. Thanks, Hannibal. Angela, could I come to you if you have any brief thoughts on that issue?
Thanks, Clive. I think building upon what Annabelle's just said, it's really making it real for people. So making it real for sponsors and delivery staff and the participants. Like, what does it mean to you when you receive those results? What difference does it make to your experience? And what difference does it make to your family or your work team? It really brings it home when you can see how you've contributed to that bigger picture. So I think that's how I would like to see it being embedded, is just making it real for everyone.
Brilliant. Thanks, Angela. And can I come to Sheena next for your thoughts on how we change hearts and minds?
Well, I thought Angela's survey was very helpful. I think disseminating those results to the research community would be really good. I mean, it's lovely to hear that people felt valued and they do take part in research again. But then it was such a shame to see the low proportion of people who knew how they would get the results at the end of it. So I think disseminating those results just to say we're not actually doing it quite well enough at the moment. And then I suppose examples of how it's been done with ease. I mean, Annabelle mentioned the challenge you have if your results come way after the last participant visit in the study. And that's often the case when you're depending perhaps on research lab results and things. But there are ways around that. There are studies that have managed to do it. So I think that helps. And then final thought really is that there are participant voices. There are organizations that can make a lot of noise if people don't do this properly, the involvement and the engagement. And I've seen that at first hand and the impact that that's had on pharma-sponsored trials. They have responded and they have done it better next time. So don't forget the participant voice in this.
Brilliant. And that is a beautiful segue into Ben. Ben, what if we can end with you and the important voice of the patient and the public, of which, of course, we all are. Ben, you're on mute, I'm afraid.
Typical, thank you. Firstly, I think I'm really encouraged by what I've heard today, because I've been banging the drum for sharing results with participants for well over a decade. So this is real progress. But in terms of changing culture and changing hearts and minds, it's not going to happen overnight. And all of the things that you've mentioned are absolutely right. We've got to inform people, and participants need to continue raising their voice. The example I would use is that in HIV trials tended to be dominated by gay white men. And so the community for a long time was challenging pharma companies and researchers to be much more inclusive with women and Black communities. Things have got so much better over the past few years. So change is possible, but it will take time and it will take effort.
Brilliant. Thanks, Ben. No, that's really important. And as I say, legislation is important. I mean, it's great that this is the first time we've put research transparency and that requirement to feedback to participants, but it's just a first step. What we really need to do is to change culture, get people to care about sharing, to understand that that's the right thing to do. But as you say, Ben, I think the more that participants push back, require it, expect it, then I think hopefully we'll start to see that change happen. So all that remains for me now really is to talk about the next steps and bring this webinar to a close. So just to end, I'd like you to know about what the next steps are for the new regulations. As we've mentioned yesterday, we published our final guidance to accompany the clinical trials regulations, and the guidance is based on feedback from a range of stakeholders who we've been engaging with over the past 10 months. It's got various updates to lots of the sections, including research transparency and sharing your results with participants, and also that data protection guidance that Alison was talking about. So as we approach the implementation of the new regulations in April next year, I hope it's in your diary, 28th of April, 2026. We advise you to sign up to our clinical trials update newsletter, and you can find details of that on our website. That will give you all the latest news and information on the upcoming changes to the clinical trials regulations and support that's available during the current implementation period and beyond once the law comes in. And all of the links mentioned in the webinar today will be shared along with the feedback form, which will be shared with you immediately after this meeting, which I encourage you to fill in and return to us, because as I say, without that feedback, we won't know what we've done right, what maybe could be improved, and hopefully that will help us in the future to create these kind of webinars and to do them hopefully at least as good as we've done today, if not better. So as we've come to the end of our session, before I draw to close, I'd just like to say a huge thank you to all of our fantastic speakers. We've had some great presentations. Hopefully for everyone, there's been some really useful information. I also want to say thank you to all of my HRA colleagues behind the scenes who have helped put this webinar together and ensure that everything has gone so smoothly. A huge thank you to everyone on this webinar for attending. Hopefully you found it helpful, useful, and as we said, all of you are really part of the way that we're going to make people incorporate this into their hearts and minds. That it's a responsibility of all of us to make sure that results are shared and that they're done meaningfully. So I hope you found it helpful. Please fill in the feedback form. And thanks everyone for today. We're a couple of minutes early, which is good. So I will let you get on with the rest of your days. So again, thank you to everyone and goodbye. Thank you.